for the last 30 years now. So there is a big friendship between us and we accept each other's complications. So don't worry, we know each other very well. So nothing is hidden from anybody. And I totally understand my friend Rajneesh. I heard him. He is a very good friend of mine. He knows what we do and I know what he does. It's fantastic. So TAVR in difficult access, which is the topic I'm going to cover today. And here what I will show you is that in those patients where we do a femoral TAVR, these are the type of valves we use. And these are the 5 type of valves which are available today in India, and all of them can be now used for non-transfemoral access also. So where do we need a non-transfemoral access? So these are some examples I'm going to show you. So first, of course, whenever we see a patient, we do a CT angio. And when we do a CT angio, we look at the valve, of course, and then we see, okay, this valve is doable. But when we look at the arteries, of this patient, we find that the access is very poor. Here you can see that the vessel size is going up to 2.8 or 4.3 millimeters, or even going up to 4.5 is very, very small, and also calcified in the entire length of the disease. And here also left side, both sides femoral arteries are not good. So what do we do? So here we need a non-transfemoral access. Okay. Similarly, another case, when we look at this, we find that the valve is good, the diameter, everything is fine. We select the valve, everything is perfect. But when we look again at the arteries, the femoral access is very, very bad. And in here you see that this descending aorta is almost 3.5 to 4, which means that we will not be able to access this patient from the femoral approach. So what do we do now? So then we start looking at different accesses. Here, a young patient who was rejected from surgery from many institutions because it was very high risk, because she had a Larsen syndrome, which means it is a multiple musculoskeletal abnormalities with very small legs. And we thought, let us look at whether we can do a transfemoral TAVR in this patient. We found that yes, TAVR is possible, but when we looked at the arteries of this patient, these were all small size, 2 millimeters, 3 millimeters, 4 millimeters. So although very smooth arteries, but very small in size. So again here, transfemoral access was not possible. So we looked at various other issues. So first of all, of course, we know that 90% of our cases are being done through femoral access, and we are able to do that. But in 10% cases, we need alternate access. And alternate access, or if surgery is possible, definitely surgery. So in these patients, we are able to pick up the right valve for the right anatomy. Why we are talking about all this? Because we heard about complications, and one of the serious complications is a vascular complication, which is because of the access related issues. And the access related issues come from calcification of the arteries, size of the sheath, which we have to use in that particular case, and also the experience of the operators at that center and the selection of the right patient. So basically, normal femoral arteries in younger individuals, we can go up to 1.1 SFAR, but in calcified arteries, we have to be a little more conservative, and very calcified femoral arteries, here we cannot go beyond 1. So that is why we have to know which size of the sheath we are going to use in this particular case, and what is the type of valve we are going to use, whether it is a sheath inline valve or it is a sheath separately which is going to be used, and also know the profile of the valve which is going to be taken, because sometimes in the balloon expandable valves, the valves are bigger profile than the entire system. So that is why we have to know all this. So what are the accesses? And here you can know that, you can see that from the if there is no transfemoral access, we can look at the subclavian axis or the axillary axis, the transcarotid axis, and also from the transcaval axis. So basically, we have to look at these options in a particular patient. So now I'm taking you to the first case where we started looking at the carotid and the subclavian axis. So when we looked at the carotid, we found that the carotid had plaquing and it was not a very healthy artery. So we looked at the subclavian, and the same CT, we can do this assessment. So we looked at the CT, and we found that the left subclavian looks quite reasonable, and the diameter was just okay, and also the path was also clean. There was no severe calcification. So in here, the same way as you can see here, that we put the same sheath and cross the valve in the same particular manner. And in here, this is a surgical cut down we do in most of these cases from the subclavian for the subclavian axis, and this is the valve which is being implanted through this trans-subclavian approach. Generally, it is quite simple approach. Doesn't take too much time, and we are able to do the procedure in the same possible way, and then close it with the surgeon. Actually, the vascular surgeons do close it very quickly. There is no problem, and nothing extra is to be done as far as the procedure is concerned. So this is the valve which has been implanted. Now the second axis is the carotid axis, which we do when we find that the subclavian also is not good. And in this patient, we found that the subclavian has a big calcific chunk at the site of where it was inserting into the aorta. So that is why we decided that it may be difficult to put the valve through subclavian. So we looked at the carotid, and when we looked at the carotid, we found that the left carotid was quite good, actually straight, nice in diameters, and the right side was also reasonably okay. So that means carotid access can be done from the left carotid access. And we have done several cases through left carotid access, which is also quite simple and easy. Again, here the patient is, as you can see, under a MAC and an IRS monitoring, which we do continuously. The anesthetists do that, and it is an open approach again. And our vascular surgeons and cardiac surgeons both are very, very experienced in opening the carotids, because it's very straightforward, simple. And now we do it without even general anesthesia. We do it locally, because they do it local carotid endarterectomies many, many times. So here you can see that it is a local carotid access. And once the access is done, they put a sheath inside. And once the sheath is in, then we take a pigtail from the other approach, which is, in this case, it was a right radial approach. We put the pigtail, and then we next went to the crossing of the valve. When the valve was crossed, we are taking this self-expanding valve. Here you can see. So any type of valve you can use depending upon the requirement for that particular aortic stenosis patient. So here you can see that we are able to position it very well from the carotid axis, and slowly release it at the site of the exact site. And the echo assessment is being done to know where we are positioning. And once everything is okay, we check it on the echo, and finally, if everything is okay, then we release it. So carotid access is a safe, fast surgical access. Less dissection is required, and the procedure is not too lengthy. It is very quick. Then the third axis is the transcaval axis, which is again a reasonably good axis. Here we enter through the IVC, puncture the aorta in the infrarenal part, put a sheath from IVC to the aorta, do the TAVR, and do the device closure of the puncture site. So in this patient, why we chose the transcaval axis? Because apart from the femoral arteries, the carotid and the subclavian were also very small size, as you can see here. So that is why we went to the transcaval axis. And in here, it is that we puncture the IVC, go into the aorta, and then pick it up with a snare, and then put the device through the help of the snare. We put the sheath inside, and the fundamental pathophysiology which is used over here is that since the pressure in the retroperitoneal space is more than the pressure in the IVC, so that is why once the communication is there, it will leak into the IVC, not into the peritoneum. So here we do the CT planning for the puncture site localization, which is quite standard. And once all that is done, we do a IVC and aortogram, simultaneously identify the renal arteries, and then go with the target site, which is below the renal arteries. We puncture the IVC with the help of a wire connected to an electrocautery, and there is you can see that the snare is inside the aorta, and through the snare we can hold this wire, which is puncturing into the aorta from the IVC. And the electrocautery makes it very, very simple. And once this is puncture is done, just 1 second is sufficient. And then we pick it up. As you can see here, we are picking it up with the snare. And once it is held by the snare, we take the whole thing up. And on this, we move the catheter so that we can now take a stiff wire on this catheter. You can see that we are taking it up slowly. And here it is going up with the sheath and the snare slowly. And once it is in position, we take the sheath inside. You can see that the sheath is being positioned from the IVC into the aorta. This big sheath is there. And once the sheath is in position, then we can do the procedure. And in here, this patient had a low coronary height. This patient had all the issues. So we had to put a stent as a protection, coronary protection here. And then once the valve was implanted, which was also giving difficulty. So we did a dilatation of the aortic valve first with the second balloon, as you can see here. And once the balloon dilatation was done, we implanted the valve inside, which was absolutely okay. And while coming out, we checked the coronary arteries if there is any obstruction or any narrowing or not. We found that there was some little narrowing. So we put a stent at that point so that there is no problem of the leaflets impinging on the coronary arteries. So once that was done, so we closed this side by a PD occluder, which actually did not give a full seal. So then we moved to the stent, which is a self-expanding stent, which was positioned here into the IVC, into the aorta, and that was released quickly so that there is no leak inside. So you can see that now there is no leak. The aorta is completely sealed and the stent is covering the aorta. So this is how we are able to do this procedure, and it works really well. So this is the initial comparison of non-transfemoral to transthoracic axis, which is almost now not existent. So we only now have the transfemoral axis and the non-transfemoral axis, which is the arteries. So transfemoral axis is the gold standard. Carotid and subclavian axis is safe, easy, and less invasive than transapical TAVR. CT scan assessment is vital in selecting the right axis. Switch before it is too late. Make the plans earlier. And transcaval axis is a viable alternative with good results. And of course, we need a good heart team with the surgical discussion and anesthesia support to take these patients out. Thank you very much. And this is one of the algorithms which one can just look at. If the size of the vessel is less than 5, start thinking of non-transfemoral axis and also looking at surgical cut downs if required. So thank you very much. And I think I will stop sharing now for some question and answers if there are any. Thank you very much.
Thank you, Dr. Praveen.
Yeah, Dr. Praveen, I mean, it was really good. I mean, as you just showed us the alternative technique, I mean, it was really excellent. The only one thing, I mean, I would say we also had one last week, one case where we had a good collaboration with a cardiologist, where we did a hybrid procedure, we can say. The patient had a LED, which was 90% blocked, and we had a Lima to LED. And when we, had required aortic valve, he's an 80-year-old gentleman who had a renal dysfunction. And we had not done a aortogram preoperatively. And when we found on the table that the aorta is porcelain, so we were kind of stuck. So the whole of the aorta was like a calcium, and there was just a small spot through which, I thought that we could pass a guide wire. And then we took our cardiologist colleagues' help, and we did a direct transaortic when the sternum was open, and we did a transcatheter valve and put a self-expandable valve as did the Lima to LED, and we could discharge the patient on 4th day. 80-year-old gentleman with renal dysfunction, and I think this is what exactly the alternative approaches are. So we are not stuck with the, I would say the femoral, and we could choose the alternative approach, and we could discharge the patient on 4th day without any problem. And so I think it's the alternative approaches, as you very rightly said, we should be really considering and thinking and take, whatever it takes to do that.
Yeah.
Thank you, sir.
Okay. I think, this direct aortic access is also a very viable access. And certainly you have to know which exactly is the side from where you can go inside. And I think, you did a good job. Thank you.
Yeah, Praveen, this is Dr. VC Chauhan.
Yeah.
Yeah, see, many vascular surgeons, they like brachial access much better than the subclavian. Is it possible to do procedure brachial rather than subclavian, which is easy to cut down, more easily accessible, and better hemostasis?
Yeah. So I think you are talking of axillary, because brachial will be too small. So axillary access is the access which we do most of the times, and that goes through the subclavian artery. So it is, they open actually the axillary artery and then give it through that. So it can be done both percutaneous or open access, no problem.
Thank you so much, Dr. Praveen Chandra, for your time and insights. Now we'll move on to our next topic.